those organized this really great conference. And it's my privilege to be here also this year. I want to thanks also for the title. We are going to discuss about what is new for treatment of advanced soft tissue and bone sarcoma. I want to disclose that I will not address GIST, neither pediatric sarcoma like Ewing sarcoma or osteosarcoma. So I would love to start by asking how many of you are having sarcoma patient in your clinic, at least a few of them? Okay. So not very many, and for that reason I don't want to go too much into details on what we can use for each sarcoma type, but more to give you a sense of how heterogeneous is the disease and how important it is to be updated every time of what is new in the field. So these are my disclosure. Okay, so this is the premise. According to the last WHO classification that was published in 2020, sarcoma is a family that comprises more than 90 different tumor types, and we are simply talking of the malignancies, not of the benign mesenchymal tumor. And in addition, we know that pathologists do identify new entities every year or refine all entities. So for example, now if we talk about angiosarcoma, we know that angiosarcoma is a rare sarcoma, but it's not a single disease. There are different molecular features according to the site of origins, the anatomic location. And this is very important because when it goes to considering which is the standard treatment for metastatic disease, of course the ISCO guidelines can provide us with a general paradigm for treating sarcoma, but they cannot enter the specific aspect of each sarcoma type, for which we need to look in the literature outside the ISCO guidelines. There is also a very important paper that has been published by our French colleague that tried in 2021 to refine the incidence of sarcomas. And looking at this paper, so incidence data and the WHO classification, the community of experts define the incidence cutoff of one or less than one case per 1 million inhabitants per year as the cutoff to call a sarcoma an ultra-rare sarcoma. Following this definition, we look at the classification, and we found that the list of ultra-rare sarcoma, which means the list of sarcoma type in which the incidence is one or less than one case per 1 million inhabitants per year, account for more than 70 different tumor types. This is again just to give you the idea of the large number of tumors that we are considering now. So if we want to look what is the standard frontline treatment for all these different tumor types, we still stick with a single compound, which is anthracycline, doxorubicin or epirubicin, which was found to be active in early 70s. So from that time on, the main drug in frontline still remain anthracycline as monotherapy or in combination, based on which is the aim of our treatment. Then, if for specific selected sarcoma types, we look at what is approved by EMA and FDA, as from frontline, we have imatinib for dermatofibrosarcoma protuberans, in which doxorubicin does not work, and larotrectinib and entrectinib for NTRK translocated sarcoma. Then we have avapritinib for the subgroup of GIST with the PDGF receptor alpha, the A42V mutation. Then we have two compounds approved only in the US, which are tazemetostat and pexidartinib for epithelioid sarcoma and tenosynovial giant cell tumor. Then crizotinib, which was approved by both EMA and FDA this year, but by EMA only for the pediatric population in patients with advanced inflammatory myofibroblastic tumor, as from frontline. Then we have nab-sirolimus for PEComa approved only by FDA. And very recently, atezolizumab for advanced alveolar soft part sarcoma. This is the only drug approved for a PD-1, PD-L1 inhibitor for a sarcoma, and this is available only in the US. Then, going back to what is new, which data are new, we have a study presented by the French colleague, in which in advanced leiomyosarcoma, there was a comparison between doxorubicin 6 cycles versus doxorubicin and trabectedin, followed by trabectedin maintenance. The primary endpoint was the progression-free survival, and in two cohorts, 75 and 75 patients for each cohort of patients, the comparison showed an advantage for the combination of doxorubicin and trabectedin. Please notice that trabectedin is not formally approved for treatment of soft tissue sarcoma, neither, of course, leiomyosarcoma in front line, and this combination is not formally usable in Europe for this patient population. The advantage was of 6 months versus 12 months. Also, a benefit in terms of overall response rate by RECIST was seen. These are the two curves which clearly show the difference. But what makes it difficult to interpret this study is the difference in the two arms related to the maintenance treatment, which was allowed in the combination of the two drugs, but was offered to patients at the time of progression outside the study for those patients who receive only doxorubicin. A confirmatory study is planned soon. The other comment we have to say is that doxorubicin for leiomyosarcoma can be an option in monotherapy, but when we need to have a major response or a longer disease control, we do not use doxorubicin alone. We use doxorubicin plus dacarbazine, as this retrospective series is showing. So for the study I was mentioning before, adramycin plus trabectedin, probably in leiomyosarcoma, the right comparator should be adramycin plus dacarbazine. So this is not currently a practice-changing study, and around Europe, usually in front line for leiomyosarcoma, the choice is between doxorubicin monotherapy or doxorubicin plus dacarbazine. Other new data are published about a very rare subgroup of entities which are generally called Ewing-like sarcoma. These are not Ewing sarcoma, these are Ewing-like, which means that they resemble Ewing by morphology, but they do carry different fusion genes. For this patient population in the past, a Ewing-like regimen was used. More recent data suggests not to offer to these patients such a long number of cycles. This is again to say that how much is important the pathologic confirmation of the diagnosis, as today Ewing sarcoma are not treated in the same way than Ewing-like sarcoma. Then, if we go to the second line, these are the drugs currently available. I'm sorry that there are some changes in the slides for treatment of soft tissue sarcoma. So we have ifosfamide, dacarbazine, gemcitabine, taxanes, trabectedin, eribulin, and pazopanib. And it's interesting to see that aside for NTRK inhibitors, we had no new drug approved for treatment of soft tissue or bone sarcoma as of 2016 in Europe. This does not mean that there are other drugs that can be used. And if you look at the ISCO guidelines, you have a list of off-label treatment that can be considered in a selected sarcoma type. And we hope that in 2003 or 4, we will also have a new compound approved for the treatment of desmoid tumor. Desmoid tumor is not a malignancy, it's a locally aggressive tumor type, mesenchymal tumor, characterized by the deregulation of WTN pathway. in which, as it is very well defined into this position paper that I suggest you to take as the reference paper for treatment of desmoid tumor, there is a list of compounds that can be used. In particular, we can use chemotherapy with methotrexate, vinorelbine, or doxorubicin, or tyrosine kinase inhibitor, in particular pazopanib or sorafenib, that are being investigated prospectively but are not formally approved for this tumor type. So for those countries in which tyrosine kinase inhibitor are not available, chemotherapy is still an option. However, recently was published in the New England Journal of Medicine the result of this randomized study, which investigated the activity of a gamma secretase inhibitor, nirogacestat, versus placebo in a population of progressive desmoid tumor. We really do not know which is the mechanism behind the activity of nirogacestat. We don't know if gamma secretase is really relevant for desmoid tumor, but the study was clearly very positive, both in terms of progression-free survival and in terms of overall response rate. Practically speaking, the vast majority of patients experience some degree of tumor shrinkage and also experience an improvement in symptoms of quality of life, which is very important in a disease that is not a malignant tumor, but is a locally aggressive disease. And the FDA is currently evaluating the activity, and we hope to get the approval in the US first and in Europe later on. New drugs are under investigation in well-differentiated, differentiated liposarcoma. Unfortunately, a study published in 2022 about selinexor, the selective nuclear export inhibitor investigated in this patient population, ended to be not very much successful. The study was formally positive, but the difference seen between the two arms was very limited, and this drug is not going to be filed for approval. But more interestingly, after several years in which MDM2 inhibitors have been tried in this patient population, as well-diff, the diff liposarcoma are characterized by the amplification of MDM2, are now under investigation. So MDM2 is important as it negatively regulates the activity of p53. So for well-diff, the diff liposarcoma is important to reactivate p53 when it is not mutated. There are several compounds under investigation to try to target this goal. The two that are currently being investigated or currently under investigation in an international randomized study are these two compounds, and we hope for positive results to be presented in the next conferences and then approval of new drugs. Synovial sarcoma is another translocated sarcoma that often affects also adolescents. It is characterized by a specific fusion gene, but interestingly, there are several fusion genes that are similar but are not consistent with the synovial sarcoma. So even here, the picture is becoming more and more complicated. It's not enough to look at SS18 to be sure that we are talking of a synovial sarcoma, as all the other are not synovial sarcoma. The fusion transcript is responsible for the disruption of SMARCB1, also called BAF47. This activates a complex polycomb system and is responsible for tumor growth. This goes through the BRD9 protein that today can be disrupted by the use of new drugs that are degraders of this protein. And we currently have two ongoing international studies evaluating the activity of two different compounds able to interfere with this protein, and we really hope again for positive results for this patient population in the near future. In addition, synovial sarcoma is one of the tumor of interest for T-cell therapy. It is characterized by the expression in most patients of 3 different potential targets, NY-ESO, MAGE, A4, and PRAME. 2 studies engineering T-cell in a patient with HLA-compatible profile have been conducted. One type is the late cell going against NY-ESO. The other one is the afami-cell going against MAGE A4. In both studies was seen some activity, in particular targeting NY-ESO. The overall response rate observed was in between 20 and 50%, and the duration of response ranging between 8 and more than 2 years. Of course, we are talking of a very expensive treatment, both in terms of cost and toxicity for the patient, but this is a very promising approach. Probably better is what is seen by targeting MAGE A4. Probably MAGE A4 is more important for synovial sarcoma, NY-ESO for myxoid liposarcoma. So the work is in progress. This is the study that is ongoing now. It is a randomized study, and results are again awaited soon, and we hope for the best for our patient. This is just to show you that with MAGE A4, the majority of patients experience some shrinkage of the tumor. So this could be the target that is going to be developed in the near future for this specific sarcoma type. And this is just to show you a patient that we treated with a metastatic synovial sarcoma. This patient already received 3 different prior lines of therapy, and he got a complete remission after this NY-ESO T-cell therapy approach. Then we have tenosynovial giant cell tumor. This is like desmoid, not a malignant tumor, but a locally aggressive disease. It's not that uncommon. The incidence is not low, but the prevalence is higher. The fusion gene is responsible for the activation of macrophage colony stimulating factor 1. And for this patient population, there are different drugs that can be used to target macrophage colony factor 1. So we have imatinib and pazopanib that have been seen to be active but are not formally available. However, imatinib is pretty cheap today, and so it is an option for patients. Pexidartinib, investigated in a prospective study that led to the approval by FDA but not by EMA. And then we have other drugs, in particular emactuzumab and vinceltinib, which are now under investigation. Vinceltinib, these are the data on pexidartinib. Vinceltinib is currently on study in a randomized trial that is open in several sites in Europe. And maybe even more interesting now, there are new products that are trying to inject this class of compound locally. So for the future, we will have to understand if it is better for a locally aggressive disease to use a systemic therapy or a local treatment. And I suggest, if you are interested in the disease, to look at this position paper by the community of physicians treating with this tumor type, in which the general principle for treatment of giant cell tumor of the joints are described. And then going to the end, just to try to tackle at least one bone sarcoma, let's talk about chondrosarcoma. Chondrosarcoma is a disease in which we can have the alteration, the mutation of IDH, more commonly in the conventional variant, less in the differentiated group. Interestingly, this IDH mutation is not the driver of the metastatic phase of the disease. It's something that can be seen at the beginning, also in benign lesions. So to target this protein maybe is not that much relevant for metastatic patient, but there are IDH inhibitors under development, in particular tivantinib, that already showed activity in a phase 1 study and is currently under investigation in a prospective randomized study. Then we have trail inhibitor, and in particular the R5 agonist, which already were investigated in a study, in a phase 1 study, showing response also in the metastasis located to the brain. And again, this compound is currently studied in a randomized prospective trial, which is also open in Europe. In the differentiated chondrosarcoma, also immunotherapy sometimes can work, although not approved in this indication. Responses are reported also in conventional chondrosarcoma. And just to end with a slide on immunotherapy, which are the sarcoma types in which some activity of immunotherapy has been seen, no matter if any of these compounds is approved or not. These are alveolar sarcoma, angiosarcoma, UPS, dedifferentiated liposarcoma, myxofibrosarcoma, epithelial sarcoma, SMARCA4 deficient sarcoma, chordoma, and chondrosarcoma. To keep in mind if anyone has access to off-label treatment or to a clinical study. For now, we do not have any predictor of response aside from histology, but the French are working on the role of TLS in this setting. So we cannot talk of everything, of course, but for those who are interested, later on we have the masterclass on ultra-rare sarcoma, in which we will address other sarcoma types and talk which are the options available for this tumor. And with that, I really want to thank you for your attention. I hope it was not too boring for you.